All right, everyone, it's Dr. Harrington. We're going to go ahead with Hospice Part 4, where we will talk about some frequently asked questions and how to answer those. Number one question that families and patients ask is, how much will this cost? And we went over this a little bit in Part 3. If a patient has Medicare or Medicaid, it is no cost to them. Everything that hospice offers is covered by those plans. Now, if they have insurance, there may be some things that the family needs to know about, like a copay or a cap, or oftentimes, again, it's no cost to the patient or the family. But that just requires a quick phone call to the insurance company. So for the majority of patients, it is no cost to the patient. Can the patient change their mind? Can the family change their mind about hospice? Of course they can. So if a patient enrolls in hospice and a couple of weeks later, they just think, you know what, I think I want some more workup for this problem, or this is just not good timing, or I don't like being in hospice, patients can revoke hospice anytime. Families can revoke hospice at any time. And if they have Medicare, it's pretty easy. It easily gets flipped from the Medicare hospice benefit back to their Part A. So yes, patients can change their mind always. When will the live-in nurse arrive? I put this here a little facetiously, but this misunderstanding really does persist, that once families sign up for hospice, there's this expectation that a nurse is going to pack a bag and come and do total care in their home for all day. And that's just not the case. So what I try to make sure that I tell families is that families, you are going to be responsible for the majority of the patient's care. A nurse will come sometimes once a week, sometimes more than that, depending on what the patient needs. An aide can come up to 3 days a week to help with baths and feeding, but the family does the majority of the care. We did talk a little bit about continuous care when a nurse can be at the bedside, but those are very, very rare and unique circumstances. Um, the other thing that I tell families is they will have a phone number that they need to put in their phone, put a magnet on the refrigerator or whatever, wherever they need to have it. They will have a phone number that they can call 24/7. Now, a nurse can't be in your house all the time, but they will have access to a nurse 24/7. So if they have a question about a medication, if that's at 10 o'clock at night, a nurse will answer the phone. If the patient needs something at 2 in the morning where they feel like a nurse needs to come out to the patient's house, absolutely, a nurse can do that. A nurse can come out at 2 in the morning. So there's 24/7 access, which is really nice because you don't get that with home health. You don't get that with anything else. But I try to dispel this myth that there will be 24/7 nursing to totally take care of the patient. That's just not a part of routine home care. Now, if a family feels like they need additional help, they can always hire additional help as well as hospice. Is a DNR required? Usually when I teach this class to medical students, I'll ask this question and almost all of them go, yes, a DNR is required. That's actually not true. So a DNR is not required to enroll in hospice and to be enrolled in hospice. The reason is that, a lot of times patients and families are just completely overwhelmed. I've just broken some bad news. We've talked about hospice care. We've signed all the hospice paperwork. We've talked about code status change. And then I come and I bring a DNR form to them to sign. And usually that's the thing that just tips it over. They just get overwhelmed. They can't deal with it. It's just too much at the same time. So hospices have said that, you know what, that's not a deal breaker. What we really want is for you to enroll in hospice. We will continue to talk to you about the DNR. So I'm really grateful that a DNR is not required to sign up for hospice, because I'm pretty convinced maybe a quarter to a half of patients that would be a real barrier for them. So what happens practically? A patient enrolls in hospice, they go home from the hospital, they get settled in their own home. home. They get to know their hospice nurse. They're in a familiar surrounding. Things kind of settle down. And then the hospice nurse starts to have a conversation with the patient or the patient's family about what is a DNR and why it's important and how this is part of the patient's goals of care. And 99.99% of time, patients or families will end up signing the DNR a little bit later, and that's totally fine. So the answer to this question is no, a DNR is not required to enroll in hospice, but the majority of patients will sign one. What if the patient lives for more than 6 months? So this happens, right? Prognostication is not 100%. So if a patient reaches kind of the 6 month mark, there is a process and a procedure. Usually an APN or the hospice medical director will go out to the house and do what they call a face-to-face visit, where it is a very detailed history and physical and getting all the information to assess the patient at that 6 month mark. And if they can show decline since enrolling in hospice, and if the doctor can say from this point on, looking forward, if the disease continues its natural course, I do believe the patient has less than 6 months. If you can show those two things, hospice benefits will be extended. And then there's a reassessment period, usually every 60 to 90 days, and you have to continue to show decline. There are times where patients get to the 6 month mark and they're doing better. It happens, especially for COPD and CHF. You have nurses coming out to the house. You've got someone paying for all their medicines. Um, so oftentimes patients do better and they no longer meet criteria for hospice. When that happens, we cannot continue to we can't commit fraud. So patients will have to disenroll from hospice and transition back to their PCP. So that does happen. And if you'll recall, the median length of stay for hospice in the US is around 24 days. So just remember, this is a very, very small minority of patients who actually do live past the 6 month mark. But if that happens, totally fine. We don't kick you out or anything. There just is a reassessment protocol. Will hospice stop my blank? All right, so we can fill in the blank with a lot of things. Will hospice stop my CHF medications? Will we have to stop the tube feeds? I feel better when I wear my BiPAP. Do I have to stop that? So again, this often persists, and even among medical professionals, there's this thought that we're just going to stop everything and just give you some morphine, and that is not, it's not true. So as a general rule, if the patient is having a better quality of life with those medications, with that BiPAP, with whatever it is that the patient is taking, if that's helping them live better, that's fine. We can continue those things. So for example, if a patient enrolls in hospice with a CHF diagnosis, hospice diagnosis, if I stop their Lasix and their ACE inhibitor and their beta blocker, that's going to be a disaster, right? The patient could have pulmonary edema, that could cause dyspnea, it could cause a worse death. So I would never stop those medications. So we continue the medications and the things that are helping the patient have a good quality of life. And we add on to things like opiates for dyspnea and things like that. Now, for more complicated interventions like tube feeds or BiPAP, that's a conversation with the patient. So for example, if I have a patient with an obstructing tumor like an esophageal mass who already has a PEG tube and tube feeds and who's tolerating them and is having a good quality of life, of course they should continue those. Now, if I have a patient with end-stage dementia whose gut is shutting down and who is vomiting all of their tube feeds and aspirating them, well, that doesn't make sense to continue those. So it's really very individual per patient. The other thing that we like to do, I'll kind of go back to the medication question because that's a really common one. We do a very good medicine reconciliation where I can look at all the medications and go, all right, let's try to get these to just a real minimum list to what you absolutely need. I know very few patients that want to take handfuls of pills in the last few weeks or months of their life. So most of my patients are very happy to stop medications. So for example, do you really need that statin? that you started to prevent a heart attack 10 years from now? Probably not. So I stop a lot of statins. I have patients that are on, 10 different vitamins a day. So we talk about that. I say, well, I don't think these are going to help you feel better. I'd recommend that we stop them. And most patients will say, oh, okay, that's fine. Some patients want to continue the vitamins. That is fine with me. It's fine. So, for the most part, when they ask kind of this very dichotomous, the hospice is going to stop this, um, usually the answer is no. And then some of the more controversial things or things that could go either way, we have a conversation about is how is this helping the patient have a better quality of life? Ooh, okay. Can we still go to the hospital? So this is a bit of a nuanced question. The short answer is yes, you can still go to the hospital. Um, what what we need to know is why the patient needs to go to the hospital, right? So, for example, if I have a patient with end-stage COPD who falls and breaks a hip, okay, of course they should go to the hospital, especially if they were pretty active and we're not close to the very end. Absolutely, go to the hospital, get the hip pinned. Now, the hospital and the hospice have to negotiate who's going to pay for that orthopedic charge, right? So, but of course, that makes sense to go to the hospital. Now, if a patient's having a symptom where the family would normally just call 911 and bring them to the ER, I go, well, let's wait a minute. So, why don't we call the hospice nurse first? Have the nurse come out, assess the patient. Maybe we can make some medication changes at home to really save a trip to the ER or save a trip to the hospital, because the goal for hospice is to keep patients comfortable and in their homes at the end of life. So oftentimes we can just make some minor adjustments at home and keep the patient home. Or if they're having a symptom that cannot be managed at home, that's a perfect patient to transition to a GIP inpatient hospice bed for a little while to get IV medications or whatnot. So, can we still go to the hospital? Yes, but it also requires some further conversation of, do we need to go to the hospital? If a patient wants to go to the hospital to get a big workup and go on the ventilator and have very aggressive care, I would question whether we're on the same page, whether this patient really wants hospice and is aligned with the hospice philosophy. So that requires a conversation. Doesn't hospice just mean that we're giving up? Gosh, I wish I didn't have to answer this one so many times. But I think that that still persists, that hospice is giving up, and that is the farthest thing from the truth. So I really try to reframe it for families is where it's not this giving up or doing everything, kind of these very dichotomous terms, right? Hospice is about providing good quality care for patients nearing the end of life so they can have a good quality of life, have good time with their family, stay home, do the things that they want to do. It's not about giving up or fighting. It's really about shifting our focus to comfort and quality of life. So and I haven't really said this in some of the previous things, but hospice provides excellent care for patients who are in their last few weeks or last few months of life. This is the best care possible that we can give patients. This is not leftover care. This is not second best care. This is excellent care for caring for patients near the end of life. So I try to reframe this for families, but this kind of language still persists. Okay, and that finishes our series. And I hope that you have learned something. And if you have any questions, please find a palliative medicine faculty member. We're happy to answer questions, teach a little bit more about something that maybe wasn't terribly clear. So thank you very much.